My name is Dr. Andrew Giacono. I'm a facial plastic surgeon practicing in Park Avenue in New York City. And we're about to start a procedure on a 52-year-old woman who's seeking facial rejuvenation. We're going to be performing a combination of procedures. She's going to be having a lateral temporal lift, autologous fat grafting to her lateral temporal hollows, a lateral canthoplasty with skin pinch and potentially a bicularis hitch, an extended deep plane facelift to treat the mid-face jawline and neck, as well as an upper lip lift procedure or bullhorn lip lift. All right, so our patient today is a 52-year-old woman who comes in with concerns for all the changes in her face that she's been seeing over the last about 7 years. So in her mid-40s, she started to notice significant changes in the upper, middle, and lower third of her face that really can't be managed with non-surgical treatments. This is common to see patients usually about somewhere between 50 and 53. The average patient becomes perimenopausal in their late 40s, and usually within 2 or 3 years of that, there are significant changes in the elasticity of the face and also changes in the volume of the face that require correction. And we'll be talking about this through the case, but some of these volume changes can be treated with volume shifts of the deep plane tissues because she's going to be having a deep plane facelift. And others require volume augmentation, and we'll be talking about those throughout the case today. But when we look at her, some of the things that we've discussed and have concerned her, starting with the upper third, is, look at my pen here, hon, right here. And this is something you can do in front of a mirror with the patient. She's noticed that there's been a descent mostly of the lateral third of her brow, which makes her, look at my finger, it makes her eyes look a little bit smaller. And it also makes her look tired. And one thing I do with all my patients is I have them bring pictures of themselves, and I'll just show you this picture, at a time when they really enjoyed their appearance. And when we look at her picture here, we can see that there's more of a significant lateral arch to the brow. The central brow, medial to the supraorbital neurovascular bundle through here, is a little bit higher, but definitely slightly higher here, but much higher in the lateral brow area. So that's been a significant change in the upper third. Also, she's become very concave in the area above the zygomatic arch, in the temporal region over the temporalis muscle. Bite down for me, hon. And you can see when she bites down even, there's been a significant atrophy of the muscle. So what it does is, instead of having a nice smooth silhouette of convexity from the forehead down into this nice beautiful cheekbone, it starts to exaggerate the cheekbone almost in a caricaturesque way. So trying to get rid of that, we'll be addressing that during the procedure. So what our plan is for the upper third is to do a lateral temporal lift, and I'll be marking her for that, and do some autologous fat grafting onto the deep temporal fascia, which you'll see me do. Under the deep temporal fascia, I'll discuss it during the procedure so that this area doesn't get lumpy and bumpy. So that's her upper third. As we progress down, look at me here. She's not displeased with her upper eyelids, and she's always had sort of a deep supratarsal crease. So she has a significant tarsal platform show, which she does not want to change. But with her lower eyelid, she's noticed that the corners of her eyes have come down. So not only has this descended, but the lateral third of her lower eyelid has come down, and her eyes to her seem like they're more rounded, and they don't have this nice canthal tilt like they used to have. So she wants to recreate that at the same time. Smile for me, hon. And we see she has a lot of significant excess skin laxity, and that's important for us to treat, because if we're going to be doing a deep plane facelift, which is going to access all this deep midfacial tissue, as this comes up, there's going to be additional skin under her eye that needs to be treated. So we'll be removing some of that skin, as well as taking care of the lateral canthal area by doing a canthoplasty, really just a canthopexy. So this will come up, the canthopexy be performed, the skin removed, and then the lateral temporal lift will remove the additional skin and soft tissue laxity. Because what we do in a deep plane facelift is we do a vertical vector of lifting. The deep skin, the deep tissues and the skin get lifted up vertically in this fashion. So we need to redrape the lateral brow and the surrounding tissues underneath the eyelid in order to create nice smooth transitions and contours. Lifting this part of the cheek up will also pad the infraorbital rim. And we've discussed about adding fat to her face, and she's concerned about it. Most times with these volume shifts from the deep plane tissue being moved, you don't need to supplement the fat as much. And if we look at her face, when she was younger, she has a very thin face. So she doesn't want to have exaggerated fullness in her cheeks. and she wants to maintain an inframalar break, which is the area right under the cheekbone. Overfilling this area can actually start to blunt some of this nice structure in a way that can be not pleasing to patients. And this is something you have to be very clear of with your patients, making sure that the goals of the contour of the midface is respected, because a lot of patients get over fat grafted through this area, and that becomes a real issue because not only the patient is dissatisfied, it is extremely difficult to correct that area once fat grafting has been excessively performed, or performed in a good way but not to the liking of the patient. As we go down into the midface area, we see that her upper lip has become elongated. Again, looking at this older picture of her, what we see is that she has a very a shorter distance from her, her nasal labial crease down to her vermilion. And some of that might be because of the fact that she had some volume augmentation to her upper lip. And that weight over time with gravity elongates the upper lip. So we're going to be performing a lip lift on her. And the deep plane facelift will treat her jawline and her neck. And we'll be doing some little work under her neck to help tighten any platysmal excess with an incision under here. So let me do the markings. That's just a brief overview of what our goals are for surgery. So we're going to be treating the middle third of the face, including the upper lip portion, and then obviously the lower third of the face as part of the facelift. Could you put your head back for me, hon? So what I'm going to start with is by making some surgical markings, which are just anatomic landmarks for the procedure. So the first one I usually start with is Batengi's line. I'm making a line that goes from sort of the lobular crease here, where it meets the face at a point sort of midway between the tragus and the lateral canthus, and then at a point about 1.5 centimeters to 1 centimeter from the lateral brow region. This is just to remind us of the course of the frontal branch of the facial nerve as we're doing dissection through this area. Over here, I'm going to mark the deep plane entry point, which is basically a line that goes from the angle of the mandible to the lateral canthal region. This is where we're going to get under the deep tissue that we're going to reposition. And what we'll see when we look at this patient is, sit forward for me, hon, is that the lateral mass in this area, and we'll talk about this during the procedure, is very, very thin and also very tight. This really is very adherent and non-mobile, but this part of her tissues are very mobile, and this is what we want to access and reposition. Put your head back. Bite down with your teeth. So as she bites down, I'm marking the temporal crest. This is the region that we're going to be dissecting over for the lateral temporal area. And I usually like to make an incision that's parallel to the lateral brow, and usually about 1.5 centimeters in length. So that's the access incision for the lateral brow area. Usually we're going to elevate and expose the supraorbital bundle, which is right about there. And we're going to elevate all these tissues into the glabellar region, because as we suspend the flap from both sides and everything is released, even though more of the lift will come laterally, the central brow will also elevate. Turn your head this way, hon. So now I'm going to mark the area for the facelift incision, and I follow the course of the lobular facial crease. I make a little bit of a geometric back cut in the area of the intertracheal incisure that goes behind the tragus here. And then I follow right at the light dark interface, right where the root of the helix comes down. I then follow the area of the temporal hair tuft. And the length of this part of the incision will be variable, because as we lift the lateral temporal area, the amount we need to lengthen this incision becomes abbreviated. Without doing a lateral temporal lift, in order to chase the dog ear, I would have to extend this incision, but we'll see during the case that the lateral brow will be suspended before we start to work in the midface, so this incision usually can become quite abbreviated. Turn your head a little bit more for me, hon. She doesn't have a massive amount of neck skin redundancy, so we're going to be able to abbreviate the incision as it comes around onto the posterior conchal surface. There's no reason to make a posterior turn on this patient because there's not enough skin that requires removal, and it would be excessive in incision lines and scarring, and it would actually make it difficult for her to wear her hair back in a ponytail. Even though not impossible, it's unnecessary in her case. Depending upon the laxity that we see here, she does have some platysmal corning. Sit forward for me, hon. And you see this platysmal excess. So I'm just going to mark some of that here now. And like we all are somewhat asymmetric, she has more laxity on her left side than she does on her right. And you can see that here. And these kinds of asymmetries are important to note If we lift this, but we're unable to be able to tighten these platysmal bands, obviously the patient won't be happy if these are not gone. This is an important thing to check on during the procedure to make sure that all that excess platysma redraping is dealt with. Great. Look at my pen here. Look up to the sky. So she doesn't have any pseudoherniation of fat to deal with. Look at my finger. So we're going to be doing a canthoplasty. We'll start with a skin pinch procedure, and depending upon how much orbicularis redundancy there is, we'll treat it. But the incision line will go past the collateral canthus just a little bit in order to be able to access the lateral canthal tendon and to be able to tighten and recreate a more canted eye and less of a round eye like she had before. And we'll work on her old pictures to do that. Keep your head back. It's important to stabilize the patient's head, and I have them take 2 fingers. I just want you to take your 2 fingers, hon, part your lips. Open them just a little bit more. And just keep your chin in one position and lift your lip in a position that you might like. What do you think?
Good, top with me.
Yeah. What most patients will show you is about 2 or 3 millimeters of central incisor show. And now what I'm going to have you do, hon, is I want you just to let go of your fingers but not move your face. Go ahead, let go. Let go. Yeah, if we look here, it's about 4 millimeters of correction or how much we need to remove. Now, when I'm marking this, I do use a caliper. And I look for asymmetries. So for this patient, if we look at her, open your mouth, hon. You know, she doesn't have an excessive tilt to the lateral corners of her mouth. So we're going to be doing sort of a symmetric excision of the subnasal area to lift the central and the lateral parts of the lip. You can move that away, Joe. You know, and this is a good time also when you're talking to the patient to discuss with them. You know, sometimes patients will want a little bit too much. Generally speaking, it's important to leave at a minimum 11 to 12 millimeters of skin between the nose and the vermilion border. That's not where I like to go to. I think that that can be somewhat exaggerated for a lot of patients. So you have to steer the conversation as well, not just let them do whatever they want, obviously. But if we mark her and we measure her, we're going to find that she has so from that area where the incision we placed, she's at about 17 millimeters. So 13 millimeters is a very safe number to leave behind. You can go below it. I think 13 is conservative, but also pretty. 14 tends to be also good, but a little underdone. 15 definitely, lots of patients will notice when they have 15 millimeters left behind that they feel like there wasn't enough done. Okay, smile big. And we can see also, if you just mark here and relax. And I wouldn't come down this far on her, but this is where she has that pleat from having a little bit of an excessively long lip. So I usually follow the nasal base. And we do this curvilinear fashion because it helps camouflage the incision when it's healing. And I'm going to mark her at about 4 millimeters. And interestingly, if you look at that, smile big, and if you look at where the crease is, relax, it's basically at 4 millimeters. So the anatomy kind of shows us where we should go in this particular case. So just marking her for that amount of skin excess. Let's see, 4 millimeters, check through that area. And then also, it's an important check to look at how many millimeters we're leaving behind, just so that's symmetric. See how from the vermilion border to the marked line, it's the same. Open your mouth for me, hon, open. What's amazing is that with this especially, you know, her upper lip is full, but once we shorten this distance, the lip will actually look not fuller, it'll look smaller. A long lip that's full looks pendulous, and shortening this distance, and I've done this on many patients who like their full lips if they've had silicone or the filler injected, once this distance is shortened, the lip actually looks pretty, even though it may be a little bit fuller. So I don't suggest lots of times just removing silicone or filler from lips. It's better to do the lip lift first, reevaluate, and then consider removing some afterwards. One more marking. Just going to be marking the zygomatic arch area and this area where there's deep temporal hollowing that we want to treat. Smell big for me, hon? Yeah. So these are areas where she has concerns of redundancy. This is just the nasolabial fold that we'll be effacing by releasing all of her deep laid midfacial tissues. Great. So those are all the markings from that side. I'm just going to complete them on the opposite side. She really has beautiful structure to her face, so that makes my job easy. She has some asymmetry between the two sides. If you look, she's much holler on this side than this side. And look at my pen here, hon. Look here. There's a little bit more of a weakening in the lateral brow area on this side compared to that side, and we'll be correcting for that asymmetry during her procedure. Great. Turn your head this way for me, honey. Perfect. There's a little geometric step off again. Great. Turn your head back towards the middle. Look right here. Awesome. Look up to the sky. So I usually put the hair up into little rubber band ties so I don't have to cut or shave any of the hair. More. Got the tape ready. Turn your head this way for me. Great. Great. Tape. And turn here. Great. Take this. Perfect. We're lucky that we have such a beautiful structure to work on. I think it's smart to get at these things a little bit earlier. You're doing a facelift on somebody in their early 50s or late 40s. There's so much more volume that's present in the face that we could reposition. It really brings much more youthful contours than we can create without adjunctive fat grafting and other ancillary procedures in patients as they approach their later 50s and early 60s. So she's a great candidate for the procedures we discussed. These are her preoperative photographs. We just saw the patient. But when we look at her in profile view and in three-quarter view, we can see that she has significant redundancy of the more medial aspects of her midface, a deepening of the nasolabial fold, significant redundancy in the area of the jowl. Even though she's young, these thinner patients tend to have sort of a deflationary effect, it appears, but lots of times it's just from gravitational descent of all these midfacial tissues. If you look at her straight on, you can see that there's significant redundancy in the perioral region in the nasolabial fold. If you look at her from the profile view, she does have significant platysmal cording that we'll be addressing both with the lateral platysmal flap and also potentially from a midline approach. Lateral canthal tilt to her eyes like we discussed. And from the three-quarter view, we can see how the lateral temporal area is not only hollowed, but the lateral temporal brow has fallen. Slight medial brow redundancy in this area. And she does have some glabellar infurrowing. My preference today is to do less corrugator manipulation. She already has widely placed brows, and I've found that releasing the corrugators, and I've done it for years, can actually splay the medial brows and create a somewhat unnatural appearance. So I'll often treat these glabellar furrows with Botox, or have the patient have them maintained with Botox at another provider's office. So the real focus of our procedure, when I look at her as a global whole, these are small procedures: the lateral temporal brow lift, filling the concavities, elevating the midface to restore some of the natural volume of the midface, straightening the laxity of the jawline, and also treating the neck. One thing that we'll see when we look at her in profile view is a scalloping that exists over the posterior mandibular line because of the midfacial tissues falling forward. There tends to be a skeletonization of the gonial angle. So you'll see me create a composite flap during the deep plane surgery that'll be repositioned over the gonial angle to add volume back in this area without the need for autologous fat grafting at the same time. If we look at it from the profile view again, what we see is that this area from the preauricular region almost to a point right here, this is the lateral fixed mass. You'll see me talk about that during the procedure. The lateral fixed mass actually hasn't descended at all. It's actually quite stuck down and tight here. If we look more forward, we see that the mobile mass, or this region through here, is what's fallen. The lateral mass that is traditionally dissected in a lot of techniques actually hasn't fallen at all, and we're going to be approaching her by entering this mass from a point from the gonial angle to the lateral canthus, which is at the region where the midface is actually fallen. So instead of dissecting this thick fibrous fascia that hasn't descended, we're actually going to focus on the area that has fallen, which is the mobile medial mass. You'll see me talk about that during the procedure. So these are just a couple of other pointers that I wanted to review before we start the procedure. We use a solution for the fat harvest. It's 1% lidocaine to 100,000 epinephrine, 50 cc's mixed with another 150 cc's of saline for a diluted solution. And this is what we use for the harvesting of the fat. We're going to be borrowing her fat from her flanks. Usually we inject about, for a region of this size, probably about 30 to 40 cc's of the solution. And the real purpose of this, with this diluted epinephrine, is to prevent there from being too much blood in the harvested fat. This has already been pre-injected, so I'm just supplementing a little bit more here. And we'll let that sit for about 10 to 15 minutes. The amount of fat we'll usually harvest about 80 to 100 cc's of fat if we're doing a full facial fat transfer. For this particular patient, we're just going to be injecting the temples. We'll probably use somewhere between 5 and 7 cc's per temple, based upon the depth of it. And usually you need to harvest about 3 times the volume of fat that you want to transfer, because you'll lose that much when you do the processing. I usually use centrifugation, but in this patient, if we're going to say use even 7 cc's on each side, that's 14 cc's times by 3, we need about 42 cc's. So I'm going to be harvesting 40 cc's of fat. The cannulas I use for fat harvest, this is a tulip cannula. It's 2.1 millimeters the port. And this is different than if we're doing nano fat, but we're not doing nano fat on her. We're just using structural fat. So I'm going to harvest 20 cc's from each flank. We use 3 finger pressure on the barrel of the syringe so that we're not exerting too much negative pressure to disrupt the fat cells. And I'm going to harvest that fat. It's helpful to kind of squeeze the fat into a little bit of a sausage or pocket, and direct your cannula to the center of that area, moving it around. So we'll take 20 from each side. When you're marking the patients for where you're going to borrow the fat, I usually like to ask the patients what areas are problem areas for them. I don't believe that any particular area has a better quality or fat take rate. This is the first 10 cc's. We'll take another 10 from this side, then we'll move on to the other side. So I like to ask the patients where they like to take it from. We'll take it from the inner thighs, the outer thighs, from the flank region. It's anywhere that the patient has a little bit of excess fat or contour problems. Even though this is not as significant as doing a body liposuction, it can be a little bit helpful to the patient. And it makes them happy. And you want to keep the cannula moving and make sure you're taking it in a uniform fashion and not gouging out a particular area, and you want to blend it as if you were doing body contouring with traditional liposuction. So this is 20. I like to use centrifugation, so after the fat is harvested, we have these little stoppers that we put on, and it gets placed into the centrifuge. I'm going to go to the other side now. Again, 3 fingers of pressure on the barrel of the syringe. There have been a lot of studies looking at trying to make the fat more viable using different methods, whether it be rolling of the fat, straining the fat, centrifuging the fat. This fat looks a little bit better. It's a little bit less bloody. And there have been some recent systematic reviews that have been published on survivability of fat with different techniques related to purification. And the jury still says that there's not so much of a difference between different techniques. I think the real problem with fat grafting is simply this: it's a free graft, and no matter how much we try to add things to the fat, like PRP, or if we use different methods of purification, the real limiting factor to fat grafting is that it's a free graft. And probably more important than anything is not how the fat is processed, it's that the fat is not over-injected and that it's in the area of vascularized tissue. So when we're injecting the fat, we want to make sure we use multiple small passes in areas where the fat has come into contact with vascularized tissue. So the method of injection is probably more important than the method of harvest or purification, in my opinion. Can I get a chromic, please, or a plain gut to close these holes? So I usually just use a dissolvable suture to close the excess holes. Just 1 stitch is fine. While the fat's being processed, we're going to inject for the lip lift. When we look at the lip lift incision, there are really 3 ellipses that are happening. There's a central ellipse in the central portion of the bullhorn, and then there's one on either side. And if we look at the largest point of that excision into the ellipse, it's going to direct most of its force in the lateral or commissure area and in the center of the lip. So we can really adjust the center and the lateral ports depending upon the patient. This patient's lip's pretty straight across, but with age sometimes the lateral corner of the mouth will dip more, so we'll take larger ports of excision in the lateral part of the lip versus in the central part of the lip. In this patient, based upon the way we did our markings on her, we wanted to leave about 13 millimeters between the inferior margin of the excision and the vermilion border. In this patient, she has a somewhat overfilled silicone injected lip that she wanted to maintain, but shortening this distance will make her lip look more proportioned after surgery. So I use a 1% lidocaine and 100,000 epinephrine mixed with 0.25% marcaine solution. It's actually a little bit less than that. Our real mixture altogether is 1% lidocaine mixed with 0.25% marcaine, and then we add 2 vials of saline, and then we add 1 vial of epinephrine. And I like fresh epinephrine because it tends to be more efficacious and cause less problems with bleeding. Lots of times the epinephrine that's put in a normal 1% lidocaine with epinephrine solution, the epinephrine is light sensitive. So what happens is that the epinephrine isn't as efficacious as you like, and the patients bleed more during surgery. And I think you'll see that throughout the facelift, is that fresh epinephrine really makes it so that the field is much drier than you would expect. So we're going to inject the lip lift. Usually it takes about 10 to 15 minutes for the epinephrine to take its full effect, which we want on our side. And then I'm also going to inject for the temple while we're waiting for the fat to process. So when you're injecting the temple with the solution,
And then throughout the face, when you're injecting, you want to inject in the plane in which you're going to be dissecting. In the area of the lateral temporal region, we're going to be dissecting on top of the deep temporal fascia. So we want to try to hydrodissect in that plane. So it is important where we're injecting because it will facilitate the dissection later on. So I'm trying to inject on top of the deep temporal fascia, underneath the superficial temporal fascia. I inject posteriorly because we're going to be elevating the flap behind the previously marked area of the incision. And now I'm going to be injecting along superior orbital rim and right below the brow. And I'm down to the bone here because I'm going to be elevating in the subperiosteal plane here. And I'm ballooning those tissues up to facilitate that subperiosteal dissection. We do want to get some medial brow elevation, so we'll be elevating the medial brow into the glabella region from those lateral port incisions. And this is all subperiosteal. Once we pass the temporal crest that's been previously marked, we're going to fall from the deep temporal fascia under the periosteum in the subperiosteal plane. This is the area of the pre-marked supraorbital neurovascular bundle to keep us mindful of its existence, but we're going to be seeing it during the dissection with direct visualization. Again, I'm injecting on top of the deep temporal fascia. Over the periosteum of the supraorbital rim and underneath the brow. Immediately into the glabellar region, past the temporal crest, on the periosteum focal. A little more hydrodissection over the deep temporal fascia. And posteriorly. So we're going to let that sit for about 10 minutes. While the fat's being processed, we'll complete the lip lift. And once the fat is finished being processed, we'll perform the lateral temporal lift because that'll give us the access point for the temporal fat grafting. Most people, when they perform temporal fat grafting, will put it superficial to the deep temporal fascia. What I found is that when it's injected in that plane, its take rate is less. In addition, it can create some lumpiness because this is a thin-skinned patient, and when you put fat in this area, any little lumps and irregularities will be very visible. If we put it under the deep temporal fascia, as the deep temporal fascia balloons forward, it'll actually create a roof over which the fat graft will not be visible. And you'll see that when I do that. It actually makes the process of injecting the fat a lot easier. And I think the take rate is higher because you're injecting right within the temporalis muscle, which is well vascularized. So my experience has been that I have much higher fat graft take rates when I'm injecting the fat deep to the deep temporal fascia than when I've injected it superficial to the deep temporal fascia underneath the skin. So we're going to start with the excision. So we saw when we pre-marked her that she had a natural break or crease here because of the length of her upper lip. It's almost like having long pants. When you put them on, you'll get a break above the ankle. So that's where her break line was. It was about 4 millimeters away, which is the place where she showed us she wanted her lip to show about 2 or 3 millimeters of central incisor show. We want to mirror the nasal base in this curvilinear fashion. And again, she has a pretty symmetric lip, and she didn't want to lift any portion of it more than the other, so we wound up doing a symmetrical excision in the lateral and the central ports. It's really important to hug the area pretty close to where that natural crease break line is, and it's very important to hug it up at the most superior aspect. So if you start to veer this way, the incision will become more visible. You want to cut the skin perpendicularly. Right? And then from here, meeting that point, and really completing those points. Very crisp, completed point. I find that most patients could benefit from a lip lift. And we do a lot of them. And I think the reason is simple. Gravity acts on all of our facial tissues. So it doesn't just act on our face, our cheeks, and our neck. It also acts on the upper lip. The lip becomes elongated, and that's one of the reasons why I ask for patients pictures from when they were younger. Pull a little counter pressure here, counter tension. As you can really see how that distance has changed over time. So this skin is being elevated, and we're going to come around the other side, right off the orbicularis muscle. I don't like removing the orbicularis. It tends to create sort of a depression in this area, and almost like an excavation cause in the area right in front of the nose. And I'll talk about that a little bit more when we're suspending the inferior lip lift skin. You can see we left a little bit of the subcutaneous tissue down here. I'm just going to remove that off of the orbicularis. Great. Bipolar. If we remove this orbicularis, it tends to create a little bit of a concavity or depression right below the nasal base, and it can look a little bit artificial and odd, so I don't like to remove it. After we've removed the skin, we want to elevate on top of the orbicularis, leaving a relatively thick skin and subcutaneous flap. It's okay to raise a little bit of the orbicularis into the flap if you need it to have an adequate thickness of tissue to suture to. You don't want to get dimpling in the skin, so it's important to leave a margin of soft tissue on the skin flap that's being elevated. You can see that here. Bipolar. It's not uncommon to get a little bleeder as you're coming around. The ala over here, suck. That's why we usually have a suction here, because we expect it. Scissor. Bipolar. Just cleaning up the skin edge there. Go ahead. But it's important to undermine in the areas where it bleeds here, because you'll get pleating and a bunching effect in these lateral corners if you don't. It's basically a dog ear because it's like the point of an ellipse, so you need to adequately undermine it. I usually undermine for about 4 or 5 millimeters. Bipolar. I don't want to over undermine in the central portions of the philtral column, because you'll start to efface the natural philtral dimple. So we have two philtral columns and a philtral dimple. If we elevate all the skin down to the vermilion, we'll blunt some of that natural architecture. And for those of you who actually do cleft lip repairs, we know we don't want to undermine those areas because it's very hard to recreate some of that natural contour and anatomy. So my preference is to maintain it. So now we have this skin undermined. You can see how far I've undermined it. Just a little bit in the center here, then go all the way down. So I'm able to maintain the natural contour, the philtral columns, and the philtral dimple. And now we'll be able to suspend the lip. And you can see the curvilinear fashion and how we mirrored that in the inferior cuts. So, forovicryl. I use a forovicryl here. The key to having vicryl not spit is making sure that the bites and the knots are buried. And in addition, it's in 1.5. It's important to have the bites not too superficial. So what I do is I will grab deeply into the tissues, but I don't cut into these tissues, and I don't try to access through more deep tissue dissection some of the deeper, more fibrous tissues to suspend the lip. I feel that when you cut into this area, just like when removing the orbicularis, it tends to invert the tissues, which creates a very harsh infranasal break that I think again looks unnatural. So without dissecting, you can access some of the deeper tissues to suspend the lip lift. And this is going to take tension off of the repair. So I always start by marking the midline first. So that's my first deep suture. Cut. You want to make sure your assistant cuts on the knot. So it's these deeper bites that are going to take the tension off the repair again into the more fibrous tissue along the nasal base. So now I'm marking and placing the sutures into those corners that we created, those wavy points. So this is going to set the position of the lip to make sure that it's not off to the right or left. Same thing here. And here's that point again. Buried bites. You see how nicely it's coming together. The real key to not having a poor lip lift scar is not having tension, undermining, and having good support to the deep fibrous tissue along the nasal base. If we look here, without even placing any superficial sutures, we can see that we're going to have a no tension repair, which is going to make this heal beautifully. So what sutures you use in the surface is actually not so important. You could do it just about any way. You could use simple suturing, you could run it. You could probably even use a subcuticular suture, even though that's not my preference. You could probably just glue this, because if the repair is correct, really the skin edges are kissing, so it doesn't require an extensive or complex superficial closure. So I'm just placing a few sutures in between those two set sutures just to support the wound further. Great. Right. More vicryl. So for the lateral ports, we half it. So I start half the distance. Again, taking a bite of the deeper, more fibrous tissues along the nasal base. And we half the closure on the other side. And you can see how nicely that lays in the corner. Cut. So the key to good lip lift scars is good undermining, good suspension of the flap, and absolutely no tension on the skin. You know, I do probably about 150 to 200 of these a year at a minimum. I haven't really made counts of them on an average week. Probably do 3 to 7 depending upon patient's preference with their facelifts. So we've done a lot of these over the last 17, 18 years. And the number of patients who wind up with problems with scarring are a very small percentage. Usually, any problems with the scarring can be managed with some Kenalog injections or some fractional laser resurfacing. And it's uncommon. Cut. And you could always revise the scar as well. When you're revising a lip lift scar, and I probably had to do it about 6 to 10 times in my career, there's less tension on the repair because you're not excising so much tissue. You're just removing the scar. But there's no higher revision rate for the scars here than would be, normally required to revise a facelift scar or an eyelid lift scar. So it's not excessive. But you can already start to see how much we can see her teeth at rest. She's lying down and there's tension here and it's swollen. So there'll be a little bit less tooth show than what you see here right now. But for me in this patient, in this particular patient, I think that this lip lift is going to be as rejuvenating for her as her facelift or any of the other procedures we'll be performing on her today. I'll usually do my closure with simple 6/0 nylon sutures, and sometimes I'll run it depending upon the patient's skin quality and type and how well the incision line has come together. But you see how nicely the areas that were predisposed to dog ears have lied down. Right. So 6/0 nylon, we're almost finished here. It's a quick procedure. It pays huge dividends. Cut. Cut. Like, even though the upper lip is full, to me, the fullness of her upper lip is not displeasing as it was before, with the distance of the white lip being longer. So her choice not to reduce the lip, I think, is going to be a good one. But if the patient wanted to, after the upper lip lift has healed, it's very simple to come back and to do a small procedure or a lip reduction to remove a little bit of the extra fullness of the upper lip, placing a small incision at the wet, dry lip junction, and removing some mucosa and a little bit of the silicone that's been permeated into the orbicularis muscle. But I think she'll be happy without doing any more manipulation to her lip. One day I'll get brave enough and I'll just put some Dermabond on this and move on to the next part of the case. And I do think that the outcomes will be similar. These sutures get removed on postoperative day 4, so they don't stay in very long. More, please. Lip lift has been completed. Now we're going to focus on the lateral temporal lift. Before we do the lateral temporal lift, we're going to process the fat. So this is the fat after it's been separated. And when we look at it, what we can see is that this is the blood, this is the fat, and there's oil on the top. So after we drain the blood off, I'll wick off the extra oil from the top. Now this is prepared to be transferred into syringes. Dr. Coleman looked at the benefits of centrifugation, and I do think that it does retain some of the stromal fractions and also probably some of the other cellular elements that are important that are not fat. Obviously, we're concerned about adult-derived stem cells. So I think there is benefit to centrifugation because it really concentrates the cellular elements, some of which I think can be helpful for fat graft survival, that are not maintained with straightening and other procedures where some of those elements are lost. But this is not substantiated by any research that I've done. But it's my preference to do it this way. It's also something we're familiar with. We've been using the Coleman approach for almost 20 years with our fat grafting in our practice. So the staff is used to it, and I'm not motivated to change what we do unless there's really good data that shows that there's a really big difference using one technique or another. We're sort of creatures of habit like most people are. So here's the fat now. And you can see we harvested about 10 cc's of fat. Her fat's pretty good. She really, 2/3 of what we harvested was fat. So out of 10 cc's harvested, we got about 7 cc's of fat, which is a good harvest for me. And now we're going to transfer this into 1 cc syringe. It's important to choke up. This is a little passer. We're not pulverizing the fat. We're using it as it came out. It's a structural fat. But it's important to choke up so you don't get air in the syringes, because if you get air in the syringes, you'll actually have difficulty injecting the fat. So we're going to get prepped about 20 cc's of fat. I don't think we're going to use that much in the temples, but I don't want to have to re-prep while we're doing the lateral temporal lift. So we'll have it ready to go. We probably will only use about 4 or 5 cc's per temple, but we'll see how the contour fills as we're doing it. This one we got about 6 cc's of fat out of 10 cc's harvested. You can see there's no air in the column of fat, because if there was an air bubble in here, as you're injecting, it would actually wind up stammering or stuttering, and as you pushed, you could actually over-inject fat, because as you're forcing against that air and pass it, you'll get a bolus delivery of the fat that follows the air that you're pushing to get out of the syringe. So how this is processed is really important to prevent those kinds of hiccups. And they're especially important when you're doing fat grafting around the eyes, where even a tenth of a cc of too much fat in one area or another will be very visible after the surgery. You can see again preoperatively the length of the upper lip, which makes her, I think, look a little bit simian. If we look on the table right now, immediately after the lip lift, we can see the change. I always evaluate the two sides of the brow before I do the lift and suspension, and to me, when I look at this image, it appears to me that the left brow is a little bit heavier. So I always like to suspend the brow that's a little bit heavier first to get it to the position that I like it, so that the brow that's higher, I don't overcompensate. And if you lift the brow that's higher, it's harder for the brow that's naturally a little bit more tonic. It's more difficult for you to make the difference between those two. So we're going to start with the lateral temporal lift now. And the important anatomic landmarks are the Arpatengi's line, to keep us mindful of where the frontal branch is, which we marked earlier. This is the temporal crest that we marked, and we want to be mindful of the supraorbital neurovascular bundle. And this incision again is about 1.5 centimeters posterior, centimeter to 1.5 centimeters posterior to the hairline, and parallel to the lateral brow, which is what we're trying to lift. For me, I like making my incisions more further forward, because the closer we are to what we're going to suspend, the better our effect will be and the more durable it will be. If we make incisions back here and we pull, the distance that we're spanning, the elevation and the effect of the lift will be minimized by the distance that we're away from it. 10 blade, when we make this incision, we want to place it parallel to the hair follicles. So the hair follicles are about at a 45-degree angle. And you like the incision line. Usually I'll make it about 1.5 centimeters to 2 centimeters long, but it's obviously well hidden. And the edge of the incision should be into the area of the lateral brow hair, because that's going to be the area that we want to suspend. Suction. So when we make the incision down to the area of the deep temporal fascia, and when I'm elevating the flap posteriorly for the repositioning of the flap, I generally want to leave a little bit of the superficial temporal fascia up into the hair, up into the flap, intentionally, because it leaves more soft tissue to suspend to. So I usually won't skeletonize the upper portion of the flap off of the deep temporal fascia. So I'll leave some of the superficial temporal fascia down, and then I use a blunt dissector. And this is a very easy plane of dissection. And you'll hear that kind of sound. As I pass the temporal crest, you fall into a subperiosteal pocket. So if you look at how far back I am, I'm pretty far back, and I do that for redraping, because if you don't do this posterior elevation, when you're lifting the lateral temporal region, you'll get a little bit of a speed bump here. So this is to minimize that speed bump. Give me a 10 blade. So when we're coming forward, we want to dissect down onto the deep temporal fascia more, because here we're concerned about the frontal branch of the facial nerve. So you'll see that I'm skeletonizing the deep tissues down until I see the real glistening fascia of the deep temporal fascia. So I left a lot of that fascia down above because I want it for suspension, but from here forward, I want to really be on top of the deep temporal fascia. And you see that there. You can see the white glistening fascia, and we want to stay on top of that fascia. This dissector I use, I call it the pancake. It's a Ramirez number 4 from his original endoscopic set that he created. This is Oscar Ramirez from Stone and Pencer. But again, as I come past the temporal crest, you'll hear the periosteum, And then if we look in here, we stay on top of the deep temporal fascia. If we're on top of the deep temporal fascia, the frontal branch of the facial nerve is up in the flap. So it's up in the flap, in the superficial temporal fascia. Once I get down to about where my marking of Patenki's line is, I'll transition into using a lit retractor. As you can see here, I'm just staying on top of the deep temporal fascia. This is all blunt dissection. And I want to continue it down inferiorly, and I'm down to area of the zygomatic arch. So we're underneath where the course of the frontal branch is. And this is probably a small sentinel vein. If you look in here, you can see a little vein that's crossing from through the field. Not all patients have very large, juicy sentinel veins. Sometimes they just have little ones like this. And if you're going to cauterize them, you want to cauterize them down on the deep temporal fascia, because up in the flap, up high, that's the area where the frontal branch is. So that one has just been buzzed. I usually don't take them unless they're starting to bleed, pancake. But as we get to this point now, so we're on top of the deep temporal fascia, we're past the temporal crest, and now we start subperiosteally to elevate the forehead flap. So this is a down biting elevator from the Oscar Ramirez set, like I told you, from Snowden Pencer. And I stay under the periosteum, and I'm elevating it over the orbital ridge. As we come past the supraorbital ridge, we dive under the arcus marginalis, which is one of the retaining ligaments of the brow. And as we move more medially, we're going to start to see the supraorbital neurovascular bundle. And if you look in here right now, what you'll see is a white stringy thing that's going from the deep surface of the skull up into the flap. That's a supraorbital neurovascular bundle. So you don't need an endoscope to be able to preserve this anatomy. You can do it by direct visualization. Once we know that we've identified that nerve, we can come medially and release the medial aspect of the orbit from this lateral approach. So now we're subperiosteal. We've released all the fibrous attachments of the temporal crest. We're underneath the arcus marginalis because you can see how far past the orbital ridge my elevator goes. And laterally in this area, as we come down along the conjoint, along the temporal crest, releasing those fibrous adhesions, there's a little bit of a confluence and of a dense fibrous nature that I call the conjoint tendon. It's been described. And when we put our finger in there, we can see that all that's been well released. So this whole brow area and all the way back, it's all been released. So my finger easily sweeps around and underneath the orbit. So we're under the arcus marginalis. We've preserved the supraorbital neurovascular bundle. The frontal branch of the facial nerve is up on the flap, and the deep temporal fascia is down. So before we suspend the flap, we're going to do the fat grafting. So now that this is opened, give me the fat, Harriet. What we can do is we can see the deep temporal fascia. So what I do is I use the tulip infusion cannula. This is a 0.9 millimeter tip. See, the infusion port is 0.9 millimeters. I'm going to perforate the deep temporal fascia with an 18 gauge. So what I do is I go through the poke hole that I've created, and now I can just fill that area. This is a gliding fascial plane. So what I'll do is, instead of having to go back and forth as we normally do in fat grafting, I can direct larger amounts of fat throughout this space. So this is 2 cc's in, and then once it's in that gliding fascial plane right below the deep temporal fascia, I can just smooth it out because it's going to glide within that plane. Fat back. So this makes the process of fat grafting in this area easier. I'll do more of the fat grafting right at the junction of where the deep temporal fascia meets the temporal crest, and along the areas where the deep temporal fascia meets the it's at its most inferior aspect, right along the supraorbital rim. So you can see I'm trying to direct a lot more of the fat where that really deep concavity and hollow was. That's the most sharp contour, is where that transition is made at the temporal crest. So now we're getting into 5 cc's of fat. I'm going to direct a little bit more inferiorly along the area of her zygomatic arch. One more. This is 6 cc's, and I think 6 cc's is going to be enough for her. It's going to give her a nice correction. So she's had 6 cc's of fat injected, and if we look here, we can see the significant concavity on the side that hasn't been treated, and a smooth convex arc from the forehead down into the zygomatic arch region from the fat grafting that we've created. But on this side, we have the deep shadowing and an over-exaggeration of her bony structure, which she has beautiful cheekbones, but because of this loss of volume through here, it doesn't look youthful. It skeletonizes the face and makes her look harsher. It collects shadows and it makes her look, unfortunately, older. So that's the fat grafting to the temple. Now we're going to suspend the brow, marking pen. And when we do this, we want to suspend the lateral brow. But if you see, now that this has all been released, the vector for the brow suspension is sort of in this direction for this patient. So I'm going to be tacking this flap up, which has been completely dissected, up to the deep temporal fascia. Fulvicral. So you play with it. So if you look over here, I think this is a little too far medial. This is where I get more of the action on the area that I want. And you see that if I suspended her here versus here, I get more elevation and smoothing of the lateral temporal area and elevation of the brow. There's a sweet spot. And now what I do is, now that I've taken a bite of that, fascia that's up on the flap, it's the superficial temporal fascia, I take a bite of the deep temporal fascia along the temporal crest. And this is a very thick tendinous layer. It's going to suspend the brow well. So when I suspend this now, the lateral tail of her brow comes up, and that looks beautiful. Brown, ovicral. I usually place 2 sutures here, and this is going to help me later, because when I'm going to be lifting the face vertically, having had the temporal tissues tightened will allow me to limit the length of my incision in the temporal hair-bearing skin. It helps take up some of the redundancy when we're doing vertical vector facelifting, which is my preference because of how it helps improve the midfacial contour. So again, I take a bite of the deep temporal fascia up high here. I use an ovicral on a Euro 6 needle. You can see how it's a perfect circle. So it makes working inside that flap a little easier to throw these bites. Great. So this was her more ptotic side. So I'm going to suspend it now before I start the other side. But if we compare the 2 sides right after this, and you have to be careful. Surgeons like to tighten things a lot. You want to make sure that there's a natural contour. This is the orbital rim. You can see that the medial brow is above the orbital rim now, and there's a nice high lateral arch. And probably the peak of it, as classically described, is somewhere lateral to the lateral limbus. Scissor, please. These ovicrals will last in the patient probably for somewhere around 10 to 12 weeks. So the scarification of the flap will be well in place. I don't have a lot of failures with these lateral brow lifts, and they do elevate the medial brow. Studies by Dr. Goyrin showed that with complete release like this and lateral suspension, you can usually get about 3 millimeters of medial brow elevation without having to do a separate medial brow suspension. The biggest problem with medial brow suspension is that, unfortunately, suspending the medial brow tends to reverse what is probably a more natural contour to the brow. Elevating the lateral brow and having the medial brow come up a little bit creates a more feminine natural arc. Lifting the medial brow with an incision here tends to elevate the medial brow more than the lateral brow, and it makes the patients look like they had a brow lift. So I don't do as much medial suspension as I was taught when I was in my training. I will use it on very heavy brows, but not so much in a patient like this who's in her 50s, who just needs lateral brow elevation. So if we look back at her, if we look here at the difference between the two sides, and this was the lower side, now we can see the difference between the two sides. This brow has an arc turning down, and this is what women start to see. The medial brow doesn't tend to fall as much as the lateral brow, a lot of patients at this age. And you can see how there's a sort of downturned sadness to the brow. And in this, you can see how we have the lateral brow up and arched, and the medial brow, when we compare the two sides, has been elevated by about 2 or 3 millimeters. This is at the orbital rim, and this is above the orbital rim. So it's a very nice technique, and as you can see, it's very quick, it's reproducible, and if you understand the anatomy, it's a wonderful addition because rejuvenating this part of the upper third looks not only natural, it makes the patients look prettier, and it also facilitates our ability to do vertical vector facelifting when we're doing the deep plane facelift like I discussed before. So now we're going to do the other side. And then we'll close. Okay. Bipolar, please. Foot pedal. Got it. A little vessel there, so I'm going to get it before it gets me. Blade. So there's the deep temporal fascia. Again, we're leaving some of the superficial temporal fascia down on the deep temporal fascia here intentionally. So it makes it a little bit easier for us to get a really substantive bite when we're doing the suspension. Again, we take that back past the temporal crest, which is why you hear me in the subperiosteal pocket as I pass it. Yeah, so going down inferiorly, you want to be on top of the deep temporal fascia. So we're on top of the fascia. Once we get to that point, we transition where the frontal branch is. We transition to using the lit retractor for direct visualization. And we bluntly dissect. Yeah, so we stay on top of the deep temporal fascia. We get down to the zygomatic arch. So this is one of the bridging veins. It's a sentinel vein that crosses from the deep temporal fascia to the superficial temporal fascia. So if you're in the correct plane, they'll course perpendicular to the plane. If you're deep to the deep temporal fascia or in the superficial temporal fascia, the vein will be horizontal. So if you're seeing that, that means you're in the wrong plane. So I usually want to preserve these unless they're bleeding. And now we're coming past the temporal crest, and we're falling into the subperiosteal pocket again. So I skeletonize on top of the periosteum, and we're elevating subperiosteally. We're going under the arcus marginalis, which is the retaining ligament of the brow. And we're going to take it medially until we see the supraorbital neurovascular bundle. And we're coming up to it right now. That's the supraorbital neurovascular bundle. So we can identify it with direct visualization. And now that we know where it is, I can complete the dissection medially. And again, I'm releasing the periosteum in between the brows. And I have a completely released brow. I release the arcus marginalis, some of the thickening of the periosteum over the supraorbital ridge, under the arcus marginalis, and we've also released the conjoint tendon. And you can see with our finger, it's a good test to do with just a sweep with your finger to make sure that everything has been elevated to your liking, and posterior as well, and underneath the arcus. And you can see that with the down biting elevator that we used before. Again, we're under the arcus marginalis. We preserved the supraorbital nerve. We saw that. And now we can add the fat and suspend the brow. So we can see the concavity here. Okay. Fat. Take that out. So we're under the deep temporal fascia, and we want to abut the fat. And the areas directed at the concavity and in the transitions along the temporal crest. This is our 4th cc of fat going in. And again, it's a gliding plane, so we can just manipulate the flat through there more. Before we saw that this was concave compared to the treated side. Now we can see we have a nice smooth convex arc that comes from the forehead through the temple area and down into the cheek. It's a little puffy right here. That's from just the local injections that we gave the patient in order to be able to localize the temporal area before. Okay. Ovicral, now we're going to suspend, and then we're going to start working on the lower lids. Now that the brow has been released. And if you look again at the medial brow, look at how it's come up. Even though we're only releasing and suspending we're releasing everything but suspending only the lateral brow. So on both sides now, the medial brow is about 2 or 3 millimeters above the orbital rim. It's that release. As soon as you do the release, the brow starts to come up even before it's suspended. It's no longer being tethered down through its attachments of the periosteum to the supraorbital areas of the frontal bone. There are very few patients who cannot benefit from a lateral temporal lift that are having a facelift. So it's not a complete brow lift, but that lateral brow does descend. This is our second bite. Again, taking a bite of the deep temporal fascia. So the reason why the lateral brow descends more than the medial brow does, or earlier, generally speaking, and suspending and comparing it to the other side. And remember, this was the higher side, so you have to be careful about how much you suspend this side, because we're matching it to the more ptotic side. So you really need to continue to compare the two sides to make sure that you're not being overzealous when suspending the brow. And always suspend the more ptotic side first. Scissor. But the reason why the lateral brow descends more than the medial brow probably has to do with the fact that there is no lateral brow elevator. So in the medial brow, the frontalis muscle elevates the medial brow. And there's also the medial brow depressors, which are the procerus and the corrugator. Laterally, there is no lateral brow elevator in this lateral temporal region. The frontalis muscle peters out in the lateral brow, so we only have a lateral brow depressor, which is the orbicularis muscle. So over time, doing, with our normal flexion, and the brow depressors working without any help with a brow elevator, it's easier and quicker for the lateral brow to descend. But if we look at her now, just with a lip lift, a temporal fat grafting, and a lateral brow lift, she already looks so much more youthful, and we haven't even approached the facelift yet. So lip lifts and lateral temporal lifts pay huge dividends, and obviously having concave or skeletonized temples is not a youthful look. So autologous fat grafting to the temples is another place where the majority of patients can really benefit from it as part of the approach to their aging face procedure. So next we're going to approach the lower lids. The patient wants a canthoplasty to be done. She feels like the corner of her eyes have come down with age, which happens obviously just like the lateral brow descends, the corner of the eyelids descend. The lateral canthal region becomes a little bit more sad looking, and the eyes become rounder in appearance, 1.5 in a brown. So I'm going to start off by doing a lower eyelid skin pinch procedure, and then I'm going to determine whether I need to do anything more to her orbicularis muscle to help tighten it. When we look at her pictures preoperatively, I don't know that she's really going to need much orbicularis work. She doesn't have an orbicularis roll on her profile view. She doesn't have pseudoherniation of fat. She does have extra skin when she smiles, and because we're going to be doing a vertical vector mid facelift in the deep plane, extra skin will be brought up under the eye, so she can benefit from a skin pinch procedure. And I think that this lateral canthal rounding obviously is worth treating. It's not severe, but she does have a sad kind of outward tilt to her eye. Her lateral canthal position is lower than her medial canthal position, so there's an outward downward tilt like this. So getting that up, I think, is going to be a really nice thing for the patient. And we'll do that with a simple canthopexy. It works great. I do a lot of them. So first I'm going to start with the skin pinch procedure on her. So it's important not to localize the patient because it distorts the amount of skin that you actually need to remove. And there's not going to be as much skin that needs to be removed medially. There'll be more skin to remove laterally. And I usually come about 7 or 8 millimeters past the lateral canthus. I'm going to need that access anyway in order to be able to get in and put a suspension suture to change the shape of her eyes. Skin pinch. A little bit medially. There's probably about 8 or 9 millimeters in this roll laterally of skin that I'm removing. Scissor ready. And then we're going to trim away that extra skin that we just crimped with the brown. Okay. You see there's more excision laterally than medially. Local. So after I get the skin pinch accomplished, I will inject local because when I'm doing the canthopexy, it'll make it bleed more, and sometimes I'll undermine the skin a little bit. And then I inject down to the periosteum here. Right. Off track here. A little uneven excision in the medial part that I'm just correcting right now. Right, local. Right, local. So we're going to pinch the other side and then we can inject it. Waiting for the local to work on this side. Right, 1.5 in a brown. Scissor. The side went a little bit better. Great. Local. Right. And then injecting down to the periosteum again, because we know we're going to be suspending the lower eyelid. Okay, great. So while that's cooking, we're going to close the temporal incisions. And then, in addition to that, we'll be, once we complete the left eyelid, we'll be injecting the face 1.5. Got it. I usually just use a .50 nylon running suture for this. Cut. Okay, cut. Great. Another one. Okay, cut. Cut. Okay. 15. So now we're going to do the canthopexy. So we make a little window into the orbicularis muscle here. And through that window, I'm going to access the inner aspect of the orbital rim. So if we look here, there are some tight periosteal attachments to the lid here. So I'm going to release some of the attachments of the orbicularis. And you can see how now there's more motion of the complex. It moves now. Before it was quite locked in. So you don't have to do a lot of dissection here, bipolar. You just want it to be free to be repositioned. Again, might be a little bit more release that's required. There, you see how that just kind of let go. So I don't want to do a complete lateral retinacular release, and I do that on some patients, but I think it's not necessary for what we want to accomplish with her, because you can see that if we take a bite of the lateral tarsal area, we could very easily reposition her lateral canthus bipolar. Try this up a little bit. So the suspension suture, through this approach, I don't need to come from above. I can take a bite quite up high on the inner aspect of the superior orbital rim cut. Let me grab it. Yep. So we just took the periosteal bite. That's on the inner aspect. You can see how far up it is. It's really kind of up here. That's where that bite is. You can see how far up it is on the superior inner aspect of the orbital rim. And now I'm going to take a little bite of the lateral aspect of the tarsus through the orbicularis. Give me a 1.5. You can see, the lid is not super loose, but we can distract it from the orbit probably about 8 or 9 millimeters. And now, once I tighten the suture, you see how it brings the cant of the eyelid up. We don't want to over-exaggerate it. Okay, 1.5. But it's going to close that lateral canthal rounding gap that she has. If you look now, you can see how the lid is not very easily distracted from the eye. There's about 3 or 4 millimeters as before, where there was 8 or 9 millimeters. So I don't do this on every patient at all. This is a specific request made by the patient, but I think it's going to look nice on her. Scissor. Okay, great. And if we look at the perspective of the shape of the eye on one side versus the other, you can see how we have a rounding effect and a more open lateral canthus here, and then we have a slight cant and a narrowing of the lateral canthal area. A lot of patients will refer to this as an almond eye. So what they want to do is they want to get rid of more of the rounding effect here, and they want it to be more supported in this area. So it's a nice little technique. It doesn't take a lot of extra effort. And now we have to close the skin. In order to close her skin, so I'm going to raise a small skin flap off of the orbicularis muscle laterally for the closure. Okay, go ahead, let go. And remember, when the midface comes up, it's going to help support the lower lid. So the closure is going to look a little bit tight before that suspension is done. Pull. Let go. Okay, give me the 6-0, please. There we go. Okay. Cut. Okay, cut. And I'm just closing the gap from where the poke hole was made into the bicularis for the canthoplasty. Scissor. Okay, great. And then give me a 6/0 back. Cut. Let's see if I can just get one more here. Cut. Again, you see. Right. So before I finish closing this, we want to get the face injected. So this is going to be an abbreviated incision facelift. This is what I usually call the maid lift, a minimal access extended deep plane facelift. So the incision will be more abbreviated, and that's possible for two reasons. One, because of the lateral temporal lift, and the other is because she doesn't have that much neck skin that needs to be removed. So the incision is going to be on the posterior aspect, the concha, sort of right by where the conchal skin meets the neck skin. Around the lobe, it'll be about 1 millimeter or 2 past the crease. There's a little bit of a geometric back cut between the intertragal incisure. This is the tragus, and this is the antitragus, so sort of in between the two is a geometric cut. This mirrors the root of the helix, which is where the skin becomes a little more shiny over the ear. And then we're going to make a decision about how far forward we're going to come, depending upon how much skin redraping needs to be accomplished. So we already know where Patengi's line was. This is the deep plane entry point from the lateral canthus to the gonial angle. And what I'm going to do right now is I'm going to get the injections completed, because as we're finishing the lids, we want the epinephrine to be completely working. So this is that same mixture that I used for the lateral temporal lift. And again, just like I talked about with the lateral temporal lift, the injections need to be in the proper plane. So I'm going to be raising a subcutaneous flap to the deep plane entry point. So I want to make these injections more superficial. That'll facilitate the subcutaneous flap elevation. If we balloon up the deeper tissues under the SMAS in this area, it'll make it more difficult for us to separate the subcutaneous plane from the SMAS. So the injections, I always say this to my fellows, is that everything matters. So even the way the injections will actually make your operation more simple and more straightforward if they're done properly and well in the right quantities and in the right plane. So I'm hydrodissecting the skin. I prefer to use a 27 gauge needle instead of a long spinal needle to save my hand. I try to inject through a spinal needle to save some more needle sticks. I don't understand really why you'd want to torture your hand that way. And I can be more specific about what plane I'm injecting in, because when I'm trying to inject on a long spinal needle far away, it's harder for me to maintain the plane that I'm injecting in. With a shorter, stiffer needle like a 27 gauge, that's definitely easier for me to control what plane I'm insecting in. So that's the subcutaneous plane back here. Similarly, this is very thin skin. We want to be right under the skin. It helps thicken the skin and balloon it up a little bit, which will make your skin flap elevation a little bit easier. So I'll usually inject about 70 or 80 cc's on each side. And even though I have an abbreviated incision, you need to do wide undermining to prevent pleating back here. So you can see that I'm injecting pretty wide for this more abbreviated incision, because the skin still needs to be redraped appropriately. And again, she has thin skin. You want to be right underneath the skin. This is going to improve our ability to control the thickness of the flap and also prevent any possibility of buttonholing the flap. One thing to note, and you can see it already, and I've already injected her, is that there's a real hollowing effect that happens with age over the gonial angle. And you can try to blob some fat in here, but the truth is that all of this extra deep tissue here can be repositioned over the gonial angle to add more volume. Fat is mushy. It doesn't really create long defined contours. It's very hard for it to do that because it doesn't have, its elastic modulus or its hardness isn't great. So what I want to do, and we'll see this during the procedures, I want to create a muscular sling that's going to be able to redrape over to this area, and it's going to recreate the fullness that we all have in youth over the gonial angle, local. So now that I'm getting past the deep plane entry point, my injections are going deeper because this is where I'm going to be. I'm going to be sub-SMAS in this area. So you can see that my needle's getting buried into the tissues a little bit more here. And in this area, I'm going to be under the malar fat. So again, my injections are deeper over the zygomaticus musculature and deep to the fat. So again, deeper injections in this area. We're under the SMAS when we're doing the flap dissection. Here superficially, this is the area of the mandibular cutaneous ligaments. If you look in this area, the tissues move freely here and they get very bunched up and they're very hard to move in this area. So this doesn't move so easily. This moves very rapidly and easily, but this area doesn't. So as part of the procedure, we're going to be releasing the mandibular cutaneous ligaments. And the face, you're going to see it. This is the zygomatic cutaneous ligaments. This all moves, this doesn't. So we're going to be releasing the zygomatic cutaneous ligaments as well. And in this area, we can see how smooth the SMAS moves. It's very locked in here. It's locked in here. And even over the midface area where the zygomatic musculature, as you can see, this doesn't want to move much. Over here, it can move very easily, but over here, it's stuck. So we're going to be seeing the zygomaticus musculature and its fibrous attachments that we're going to need to release there as well. Over the masseter, there are some masseteric cutaneous ligaments, and you see them here. This is the position of the masseter muscle. This doesn't want to move much either. So you'll see us release the masseteric cutaneous ligaments in this area, but when you get it forward to it, everything moves readily. Over here, things are stuck. These are the sticking points of the face that are really an important tenet of the deep plane facelift. It's not just deep tissue elevation, but release of the ligamentous structure of the face that allows for large shifts of the deep tissues, which allows for really mid-facial elevation and better jawline redraping. I'm also injecting the submentum because we're going to be elevating the neck skin tissues. And she's had old therapy, which never makes me happy. So when patients have old therapy, they lose some of the subcutaneous fat in the neck and they get a lot of fibrous tissue, which makes the skin flap elevation of the neck more difficult. So I'm especially careful to hydrodissect and really make the neck wet or filled with the local anesthetic fluid. It definitely can help break up some of the scarring before you're elevating the flap and make it easier to elevate it. I have patients who've had 3, 4, 5, or sometimes more full therapy treatments. It's very common for women in their 40s and early 50s to try to avoid a facelift by doing some kind of energy-based tightening device with old therapy, with some of these invasive radiofrequency treatments. whether it's high-intensity focused ultrasound or direct delivery of RF to the deep tissues with a probe or cannula, it's frying the fat and it's creating a scar plane. And what it also does, unfortunately, is it destroys the subdermal plexus, which is the blood supply to the skin. So often patients who have had old therapy, if they've had multiple treatments, their skin will behave like a smoker's skin. So they have a higher rate of skin necrosis, and you have to be very vigilant for that post-op day one, because if they're having issues with blood supply, you can put them in a hyperbaric oxygen chamber and you can salvage their skin. And I've done that many times for these patients. I'll often discuss it with them preoperatively about the possibility of needing hyperbaric, even though it's not usually required in the majority of cases. But if the skin looks dusky in any way, post-op day one, in the areas that were treated with these energy-based devices, usually within 24 hours, if you get them into hyperbaric treatment, you can salvage the skin and have a lot less issues in a prolonged post-operative recovery. But you can see how her skin is resisting the hydrodissection. That's from the scarring from the old therapy. So spending a little bit of extra time here is going to pay huge dividends and making it easier for me to dissect this flap when I get into the neck. It's important to inject the areas around the mandibulocutaneous ligaments a lot too, because there's blood vessels that come up through them, which tend to bleed a lot. So if you can get a good injection, some vasoconstriction, it'll make your life easier when you're trying to control the bleeding during the case. Great. So now that the injection is completed, I close the incision line here with the 7/0 nylon. This is a 7/0 silk. Cut, please. What's up? Okay. Cut. Okay, great. So I'm going to do the same thing on the other side while the epinephrine is wearing in. We're going to make a poke hole through the orbicularis again. Sharp scissor. You can elevate a flap underneath the orbicularis. Over the periosteum, 1.5. See again how the lid doesn't want to move, it's very tethered. So I'm going to release some of those inferior attachments along the inferior orbital rim. You see how that just released and it popped forward. Wouldn't do that before. See, now we have more mobility to the lid that we didn't have before. And the lid can be distracted about 8 or 9 millimeters from the globe. And once we suspend this, we're going to see how that's no longer possible. And then I'll take the six out. I'm taking that bite up real high. Okay. So, I mean, that bite is up here. It's all the way up there. So you don't have to make a separate incision. If you're doing an upper blepharoplasty, You could potentially throw that bite from the through the upper blepharoplasty approach, but lots of times you could just get it from the inferior approach. Again, we take a bite of that lateral canthal area into the lateral tarsus, and then I'm going to tighten that. Before I finish, I'm going to compare it to the other side. And you can see the lid is not easily distracted away from the globe. So about 2 or 3 millimeters able to be distracted from the globe. You know, it's always a good test too to make sure you can stretch the lid margin above the globe. She doesn't have proptotic eyes, but if you over tighten this kind of a suture in a patient who has a negative vector or very prominent eye globes, you could pull the lid margin below the globe, which will obviously make the patient not only lateral canthal rounding, but also will have the patient have significant scleral show if it pulls below the globe. And if we compare it between both sides, I think we have good symmetry. And if we look at her from the front view, this eye has more lateral canthal rounding when we're working on, but she also, that's because she has a more prominent eye. This left eye that we already operate on is a little bit enophthalmic, and the right eye is a little bit exophthalmic. So the eye comes out a bit, and as a result, the eye looks bigger on this side than it does on this side. That's not something you can correct with this procedure. We'll create more symmetry. But if we look back at the patient right now, you'll see this slight difference. This eye looks a little bit larger on the right because it's coming out of her orbit a little bit more. So even though the pitch of the lateral canthus is similar, we're not going to be able to force the eye in or make it more retruded into the orbit because of what we did to her lateral canthus. So she'll still have that difference between the shape and the two sides of the eyes, even though I think it'll be better because the correction was greater in terms of the amount of scleral show, and lateral canthal rounding was a little bit greater on this side. So pull down for me here. So we're going to release the skin again just above the orbicularis. We'll do the closure and then we'll start the facelift. So I'm just elevating the skin off of the orbicularis. Let go. Okay, can I get a 6-0? And again, when this mid-face comes up, it's going to support the lid more, which is great. So we can be a little bit more aggressive with this skin removal as we have been. Okay, great. 4 vicryl, cut. Great. Vicryl. I'm just taking a periosteal bite here. All right. To close a little bit of the gap. Okay. Okay, so I'm taking a small periosteal bite to close a little bit of the gap of the orbicularis from making that window to do the canthopexy. Scissor me. 6-0. Seven oh. Cut. Cut one. Hold the lid up. Okay, let's get the 10 blade ready. Okay. Right. 1.5. So if we look at her now, you know, the lateral canthal area has been shored up. Lateral temporal lift lip lift. The face, even though we haven't lifted it yet, the visual axis of the face is up here now, not down here in the lower third of her face, because of the lip lift and all of the elevation of the tissues in the lateral canthus and the lateral temporal region. And now we're going to focus on the face. So again, in review, I'm going to be releasing the masseter cutaneous ligaments, the zygomatic cutaneous ligaments, the ligaments overlying the zygomaticus musculature that tether the midface, and the mandibular cutaneous ligaments. 10 blade. I'm going to start with the incision and the subcutaneous dissection. The pre-marked preauricular region where the lobule meets the face. Geometric step off at the intertracheal incisure. Stay right at the dark light interface, right where the root of the helix is. And then we're going to follow the temporal hair tuft. I'm going to stop about there, because we'll see how much extra skin we need to remove later on if we need to make that incision further. I don't prefer to go up into the hairline, because no matter what you do, if you're doing a vertical vector facelift, you're going to wind up elevating the temporal hair tuft, which I think looks extremely unnatural, but a lot of patients wind up with that look after their surgery when they have a facelift. Incision line just slightly past the sulcus of the concha with the neck, and then as we come around the lobe, you leave a little bit of rim skin right where the lobule meets the face. So we're going to start the elevation of the flap subcutaneously, and I start with the 10 blade. Fascia over this area tends to be fixed, so it's a little bit harder to dissect this skin with just a scissor, so I prefer to do it with a blade, just because it's faster for me. Bipolar, so there's usually little perforating vessels from the superficial temporal vessels here, so I usually have to cauterize some of these vessels. Great. Now that we have the flap started, I'm going to start with a backlighted flap technique. As I backlight the flap, my assistant's going to be a far distance away. If he's too close retracting, I can buttonhole the skin. And then I look under the flap, and I start to elevate the skin. And the reason why I do it this way is because the transillumination of the light through the skin can give you a predictable sense of the thickness of the skin flap. So we're raising a subcutaneous flap here. And again, the amount of light showing through that color lets me know that the flap thickness is contiguous and even throughout. When you just use a headlight and you look in, it's harder for you to tell how thick the skin flap you're raising is. So we're backlighting the flap, and the transillumination of the light through the skin, we can see the thickness of it. The thicker the flap is, the less lighted the flap is. But if we look in here, we can see the subdermal plexus. Those are those little cobblestone of little blood vessels. That's how we know we're in the right layer. And the thickness of the flap is uniform because we see that the color of what I'm elevating is uniform. When you see it getting darker, that means the flap's too thick. If it looks very, very light or white in appearance, that means you're thinning the flap out too much. It's important to elevate the skin flap high up into the temporal region. And it's in the subcutaneous plane, so the frontal branch is protected, because if we don't do that and we lift vertically, we get pleating here, and we don't want pleating. So it's important. People are often afraid to elevate the skin here because they're worried about the temporal branch. If you're subcutaneous in the right plane, there's no risk to the nerve. So now the flap has been elevated to the deep plane entry point, which we pre-marked. So this is all subcutaneous dissection. And I'm going to just put a piece of gauze here, and we're going to elevate the next skin flap. Double prong. We're going to do the same thing. We're going to elevate the next skin flap. I use a blade again to start. Things are quite fibrous and attached here over the area of the mastoid and the sternocleidomastoid mastoid muscle. So I start the flap with sharp elevation, and then I'm going to transition again. Great. So you can see that the subcutaneous flap is being elevated. And you can see the transillumination, how there's a uniform color and transparency to the skin. It's being elevated off of the fascia overlying the sternocleidomastoid muscle. As we come past the SCM, I use a lighted retractor, and I'm accessing this fascial plane. That's this white fascial plane overlying the platysma muscle. With vertical blunt spreading on top of the fascia, I use a longer scissor now, and I can stay on top of that fascial plane. So I'll use this longer lighted retractor to do a lot of the neck skin elevation from the lateral approach, and I'll use this longer scissor with vertical spreading. So I'm not cutting, I'm spreading over the fascia. Get a 4-7, get the skin out of the way. So I'll spread bluntly over the fascia, staying on top of the platysma muscle. But I'm staying on top of the platysma. That's the platysma muscle right there. So I'm on top of it, and that's the actual band that we pre-marked from before. Vertical spreading. So if we go over top, we'll see that we've elevated the skin right into that area where the platysmal band is. Right through here. So that's about as far as the dissection as we can get from lateral. So now we're going to transition to make a submental incision to complete that dissection. Usually I make a 1.5 centimeter incision, and I make it up high. A lot of people in the literature talk about how it's important to place it low to prevent creasing or a bulge here. If you circumferentially elevate the tissues around this incision, it will not pucker. So I think that it's preferable to hide the incision up higher, because an incision down here can be more visible. So this is just to complete the skin elevation in the midline, and we're also going to be treating the platysma usually after we suspend both sides in a case like this. So I'm elevating the skin. Thankfully, she's not as fibrosed from her therapy treatment. Okay, give me double prong. So go ahead, pull down. And I'm elevating the skin all the way down to the level of the cricoid. Here. And you can see that we have a very long neck skin flap. And I'm going to elevate some of the platysma and this, over the platysma of the skin here in preparation for when we get to the other side. You can see she has a large EJ there. It would be a real disaster if we nipped that from this approach. So you have to be careful when you're working blindly this way. Round. So now I'm going to release some of the mandibulocutaneous ligaments marking pen through the midline approach. We'll get it from the lateral approach as well later, but this is those areas that are fixed, and we've already pre-injected them. I'll dissect them out in a subcutaneous plane. Gold handle. Okay. So you can see that area that we marked out before. Okay. So you can see how we've elevated a lot of that. So now this skin rolls, whereas on this side it's very locked in. So this is going to make it so that when we redrape the skin along the jawline, we won't get a pleat. A lot of patients after they've had a facelift will wind up with a pleat right in the area of the mandibulocutaneous ligament that was not released. That won't happen now because this has been released. We're going to release the other side, and then we're going to go back and start the deep plane dissection. So again, it's a subcutaneous dissection. So because it's subcutaneous, The marginal branch of the nerve is not in the subcutaneous plane, so it's safe. Great. Now you can see how this all rolls. It's no longer tethered. Give me a stores. And I'm going to release some of the skin superior to the incision here and connect it to those pockets that I created for the mandibulocutaneous ligaments. This is what prevents puckering. It's circumferential undermining. The incision's an access point. Whether it's here or there, if you don't adequately release the tissues around it, you can get a pucker or a pleat where the skin was still adherent or attached. So that's the release of the mandibulocutaneous ligaments. You can see how the skin will roll all the way up over the jawline now. So now we're going to go to the deep plane dissection. So we've elevated the skin to this deep plane entry point. Now, one thing to note is that the fascia over the preauricular region is very fixed. So lateral smash approaches that lift all of this fascia, whether they be above the zygomatic arch. The zygomatic arch is right here. It's between my two fingers. So if you're doing a high lateral smash approach, you're making your incision up here and forward, and you're raising a huge flap all the way forward. The problem is, and I used to do a lot of lateral smash approaches, is that the smash here is very, very fixed. It's fixed to the preauricular tissues and the parotid. It's never descended. And we saw that from her pictures before, that this area here, you can see how the lateral smash area is very, very tight and hasn't fallen. It's all the stuff anteriorly. So there's this fixed smash and then this medial mobile smash, but this lateral fixed smash has never been descended. So most smash procedures focus on this layer, which is very fixed to the face, not the mobile smash. What we want to do is we want to get at the tissues and we want to act on the mobile smash. See how much this smash moves? So we want to release this smash, which is the mobile smash, and reposition it. We don't want to pull on this or elevate this in an attempt to get at what is really fallen. And these are those areas where it's tethered. So the mobile smash is tethered over the masseterocutaneous ligaments, the zygomaticutaneous ligaments, the zygomaticus musculature, and we've already released the mandibulocutaneous ligaments. So at the deep plane entry point, I'm going to engage that with this 5-prong retractor. And what I'm going to do is I'm going to enter the smash all the way forward. So I make a 10-blade cut into the smash until I see this fascial layer. And if I press on it with a gauze, you can see how there's this white fascial layer that's developing. And then I go again, let go. And I engage it a little bit higher, and I pull up, and then I score the smash again. And then same thing, I go up higher. And then from underneath, I'm going to score the smash again. Now, the smash doesn't really live up in this area. What we see is we see fat up, which is the malar fat, and we're going to see the orbicularis muscle, fibers of it. So here where we made this cut, there's no smash in the upper midface. We're on top of the orbicularis, so we're under the malar fat. So that is a transition point. Marking pen. The zygomaticus muscle is really about here. So the smash really lives inferior to the zygomaticus muscle. Above and medial to the zygomaticus muscle up here, there really isn't any smash. There are the ligaments and there's the malar fat pad. So when we're above here, when we're entering the deep plane, along that deep plane entry point, in this area we encounter the zygomaticus muscle, the zygomaticutaneous ligaments, and the orbicularis muscle. When we enter the deep plane through here, we want to be on top of the mimetic musculature. Down here, we're under the smash on top of the masseter, and there's a transition point where the smash ends and the subcutaneous, really superficial to the zygomaticus muscle flap begins. It's a thick blanket of malar fat and skin, but there is no smash, and we're on top of the mimetic musculature here. So there is a transition point through the midface where the flap goes from being a composite smash flap to a composite flap with the malar fat here, and we'll see that as we dissect. We're going to start our dissection at the inferior part. And what I do is I do some vertical blunt dissection. So what I do is I do some vertical spreading. And you see how we start to develop a flap over the masseter. So this is vertical blunt scissor dissection. And it's a nice fascial plane. It doesn't create a lot of force. And as long as we're under this mass here and on top of the parotid-mesenteric fascia, the nerves are protected. Why? Because the parotid-mesenteric fascia carries the facial nerves. These are the parotid-mesenteric fascia right here. The nerves carry that. We're under this mass, and if I put this scissor in and we go over top, we're under this mass all the way to the area of the jowl. Instead of dissecting the lateral mass out here and ending here, most traditional SMAS surgery techniques, whether they're high or low, will dissect a SMAS flap that goes from high and lateral or low and lateral anteriorly and stop somewhere around here and release some of the zygomatic cutaneous ligaments. What we do is we bypass the fixed SMAS, enter the mobile SMAS, and actually lift what has fallen, which is the mobile SMAS, and we lift it all the way to the areas that have become ptotic. So we're really lifting what has fallen. And you see we have the beautiful fascial plane, it's gentle dissection, the nerves are not traumatized. As I come around, I stay in that fascial layer and I'm under the platysma muscle. The platysma muscle fibers are up, you can see those. So I'm dissecting around the turn, I'm going below into the neck, I'm under the platysma, and this is setting up my platysma flap for later in the procedure. But if we look in here now, we can see that I've elevated the platysma muscle for about 5 centimeters below the angle of the mandible, which is where I entered the deep plane. So we're going to be releasing this platysma later. We're being tethered as we come up by the zygomaticus musculature and the zygomaticus cutaneous ligament. We don't want to continue to dissect in this direction because we can dive under the zygomaticus and hurt the zygomatic branches. Over here we have the orbicularis fibers that are down, and I use this to retract and pull up against the tissues, and then I bluntly dissect and I find the pocket that's over the mimetic musculature. We see fat up in the flap, so up here is fat, you can see the yellow fat, and we're on top of the orbicularis. So with that brunt spreading, I can continue this dissection. That dissection proceeds on top of the mimetic musculature all the way forward until we're all the way at the nasofacial crease. So all of that has been elevated. But when we look now, we can see where we're tethered by. Marking pen. This is really the location of the zygomatic cutaneous ligament. So there's a superior and inferior pocket, and you can see the midface won't move unless that's released. Now up here, you can see I drew it a little bit higher than it really is before. Now we're going to release that. So now what we see is this is the zygomatic cutaneous ligament. It's a very dense fixed ligament and it holds the whole midface. So what I'm going to do now, and these are fibers of the zygomaticus muscle, I'm going to release the ligament and I'm on top of the mimetic musculature. So you see the zygomaticus muscle coming into view, and then on top of the zygomaticus muscle, I'm going to release all those fibrous attachments into the midface. So I'm chasing the zygomaticus muscle. I've released the ligament, and I'm going to continue that forward until I release the entire midface. So now the entire midface pocket is elevated. This is the zygomaticus muscle right here. And this is the pitch of the zygomaticus major muscle from this patient. If I take my fingers and I place them underneath into that area, we can see that the whole midface has been elevated all the way to the nasofacial crease. So all of this deep structure now is elevated so we can reposition it. Without releasing this, if we're trying to lift all of this stuff here from all the way back here, you can see how it's not going to move very much. But now we have a complete composite flap that can be redraped. So now we're going to release the platysmal flap. So the deep plane flap is up. I'm going to mark the area where the platysma meets the sternocleidomastoid muscle, and I'm going to make a cut along that line. I've already released the platysmal flap from the other side. And you can see I'm scoring and I'm lifting up. I'm scoring the platysma and this white fascia here are the cervical retaining ligaments. Give me a patch. So now what I do is I take my lit retractor and you can see this white fascia, and I'm going to break through those those ligaments, and I'm going to fall into the pocket that I created before. And now, what we see is if I place my scissor underneath the platysma, I've elevated the platysma all the way to the area of that platysmal band. So it's very, very far forward. So we have a long platysmal flap that we'll be able to use, and it goes down for 5 centimeters. So we'll be able to redrape the platysma and to really work on that band without having to do too much work midline. So now I'm going to irrigate the face and get it ready for suspension. So we use a combination of gentamicin and bacitracin irrigation. Okay. I should mention that, and I forgot to talk about it before when we were injecting the patients. You can see how there's not a lot of bleeding. It's definitely from the epinephrine, but we also use tranexamic acid in all of our cases. This is our local preparation because patients always, the visiting colleagues always ask us what we use. So it's really lidocaine, sensocaine. We now use 10 cc's of tranexamic acid. We put in more than we used to. We don't use 5, we use 10 cc's. And then we use 1 cc of 1 to 1,000 epinephrine. And we dilute it with a little bit of extra NaCl. So it's 50-50-50, 1 cc of epi, and now we use 10 cc's of tranexamic acid. So that definitely helps with hemostasis. So there really isn't a lot of bleeding. What we can see here is the orbicularis muscle down. This is the zygomaticus musculature. This is the parotid mesenteric fascia that carries the nerves. Sometimes you'll see a nerve scoot from here under the zygomaticus musculature. I don't see it in this case. This is probably a nerve that's carried in the parotid mesenteric fascia. This is the platysmal flap that we just elevated. And the marginal branch is down in the superficial, the deep cervical fascia. People are worried about lifting this platysmal flap because they're worried about hurting the marge. The parotid mesenteric fascia is contiguous with the deep cervical fascia, which carries the nerves, so they're all on the same plane. So if you're under the SMAS here, you're safe, and if you're under the platysma, the nerve does not exist in the platysma, it's in this fascia. So if you stay in the right plane, you'll be safe. What I'm going to do is I'm just going to make sure that there's no additional attachments in that area where the mandibular cutaneous ligaments are. And you can see that there was a little bit there. But now I can bring my finger all the way above past the jawline. The jawline margin is down here, so I know I've completely released the mandibular cutaneous ligaments because I'm this far above the mandible. And that'll make it so that this redrapes. You can see how much this redrapes now along the jawline. So this patient has extremely thin skin, so what I'm going to do is I'm going to take my first bite into the SMAS of this composite flap, look up, and you can see that I'm elevating the tissues so far medially. Usually I'll place 5 or 6 sutures along the deep plane. So this is where they are. In a traditional SMAS procedure, the suspension is all the way back here. Whether it's high or low SMAS doesn't matter. And it obviously makes sense that if we're accessing the deep tissues and suspending them forward, we're going to get a much better effect than we can get on these tissues from far back here. In fact, it's fair to say that it's probably 3 or 4 centimeters more anteriorly in most faces where we're suspending the deep tissues in the SMAS from. So I'm going to place those sutures in now. And this woman has a very thin face. And we're fixing it to that fixed fascia, the preauricular region. And you can see right here that the deep plane is somewhat attenuated in this spot. If we go back to her images, we can see that there's a hollowness through this area and a concavity in the lateral view on both sides. So there's not going to be as much tissue to purchase in the deep plane, so we're going to take bites of the deep plane above and below that hollowed out area. So here's that hollowed out area. So this is the deep plane above that concave area. So we're going to be suspending from there. And these sutures are being placed now. That's the area of the zygomatic arch periosteum. It's a fixed and stable point. And as we come higher, here. A lot of that suspension is going to be happening pretty high up. In fact, much higher than the zygomatic arch. The zygomatic arch is here, and you can already see that this suspension suture is going to be quite high above that area. Needle driver. You'll see that this superior suture really helps support the lower eyelid margin. Awesome. Great. Scissor. So we're going to start suspending the most inferior suspension suture. Great. And I start from inferior to superior because I want to redrape as much of the tissues up vertically as I can. If I started superior then worked inferiorly, I'd be limiting myself. So I'm recruiting tissue from inferiorly and bringing it up. And it's important with these sutures not to over tighten them. People often ask me why I don't really pull on these SMAS sutures, because most people when they do SMAS flap procedures they're really cranking on the tissues. And the reason why I don't is because I don't have to, because I've already released all the tissues. So I'm not fighting against the SMAS that I haven't released, and I'm not fighting against the ligaments that I haven't released. So this is really like making a bed. It's just redraping the covers. Let go. There you go. Hold this here. Can I get some alcohol swabs? Okay, great. And you compare the two sides now. You can see how this midfacial tissue has been redraped up high. This is centered here, but also if you look at the posture of the mouth, the corner of the mouth has been elevated, and this is still drooped over the lip and the teeth, because when we lift this up, it's going to similarly bring the oral commissure and the lip above the teeth. So we can see, you know, back to really probably the area of her first molar on this side, where it's very shadowed on this side. We can see that the lip is up. So the midface has been repositioned. If you look at the vector of the flap redraping, it's really, you know, in this direction, right? So the flap isn't redraped this way, everything's coming this way. And if we, you know, look at it, it's probably about perpendicular to the nasolabial fold. So that's the redundancy of the midfaces being lifted in that dimension. Here's the platysma flap that we've created. And what we're going to do is we're going to feel for the gonial angle, and we're going to make a back cut in the platysma right at that level. And you can see what it does is it creates this platysmal flap that will tuck up under the jawline. So it's going to force and place most of its force quite anteriorly right where that platysmal band is. So if I put my scissors right here where that anterior edge of that back cut is that the back cut is all the way forward. So the platysmal flap pull is exerted right here, which is very close to the platysmal cord. So this platysmal flap now, there's the fascia from the cervical retaining ligaments is very dense and very fibrous. So what's great about this is that we're not biting into the platysma muscle, because that's like wet tissue paper. And then I take a bite here up in the area of where the SCM meets the mastoid. And when I fix that tissue, that flap, I call it a platysmal hammock. It helps support the area right underneath the mandibular line, and it can actually help support slightly ptotic submandibular glands, and we have some studies coming out about that. But now if we look down, there's a little bit of redundancy here where the platysma was redraped, and I'll place a second suture into that flap. So I take a bite of the anterior parts of the fascia of the SCM, and I take a bite into this platysmal flap. And then I suture it. So now the platysmal flap is secured. We'll see how much definition we have along the mandibular line and the submandibular contour has been supported without removing even any skin at this point. This inferior portion of the flap, which is above the myotomy, is additional mass tissue that we're transposing posteriorly. Making the cut in the platysma here allows this tissue to rotate forward, superiorly, and over the gonial angle. So this is going to add volume back to the posterior gonial angle and prevent it from looking scalloped like it does in the aged patient. What this does is it creates a more elongated, fuller looking jawline, which is in no way masculinizing. It just recreates the natural arc of youth, because as we get older, we get more concave in this area. And if we look at the area which was concave, this is the area where that flap was transposed. This was that depression before, and now that flap reestablishes the gonial angle contour. So that's from that last suture with that smash flap that we put there. So the jawline looks longer, because before, when this was concave, it looks like the jawline is shorter. So now we're going to trim the skin away. I usually place a drain. So now the flap has been redraped, and we see that the skin around, even though the deep plane flap has been fixated, we can still change the direction that we want to remove the skin. So this is where the fixation points are for the deep plane. We can still pivot where we want the flap to go. So the skin doesn't necessarily need to move in the exact direction of the deep plane. The deep plane is for the deep tissues. But generally speaking, we want to try to avoid a dog ear here. And we are able to, and we have an abbreviated incision because of the lateral temporal lift. And you can see most of this flap redraping is more vertical. So it's not a lateral redraping, it's a more vertical redraping. Marking pen. So we mark the first point. Of suspension of the flap. Marking pen. Blade. And the real key to having good incision lines is that the skin should really just kiss. Even without any deep sutures, there should be no pulling on this. Okay. So a lot of people talk about beveling incisions here. You could do that. I don't think that that's what's really important in terms of creating seamless incision lines. It's a complete lack of tension on the incision line. I'm just getting rid of a little dog ear here. Okay. Figril. Okay, it's got a okay, 5-1 Allen. So we needed to chase the incision line a little bit forward because of the extra redundancy in the skin. We would have left it with a dog ear. So the lateral temporal lift helped. And if we hadn't done it, we would have had to chase the incision line much further. like another probably 1.5 to 2 centimeters. We're going to have an abbreviated incision round. We published a paper about this. We call it the minimal access deep plane facelift. So the incisions blade are smaller. It's limited to the postauricular crease, so there's no turn in the back, and this is the ideal patient for it. For nylon. So a lot of the contouring in this neck comes from the platysma muscle redraping, not from skin removal, because she didn't have that much skin to remove in the first place. Cut. Additionally, a lot of the neck skin has been redraped up into the face. Not pulled in this direction, it's been pulled more in this direction. Once that's been set, there's a little bit of a margin of skin that gets removed here, and then the skin gets redraped and suspended into the postauricular sulcus with the forovicral. Cut. So I'll split the difference. I'll continue to half it. I usually put 3 or 4 sutures, and I try to take a little bit of a bite into the fascia, the deep fascia here, to help secure the position of the flap against the postauricular sulcus. So 3 deep sutures, and then I'll just put simple 4 nylon sutures here. Scissor. Cut. So this could be a little bit lumpy in the beginning. It usually takes a couple months to settle out, 2 or 3 months. Patients are often not aware of it unless they rub their fingers behind their ear, because it's not in a visible spot. Cut. 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 Great, you gonna go? Okay, so we finished the left side. Now we have to prepare the right side of the face again, with the local anesthetic injections, being mindful of the planes of dissection. Remember again, when we're lateral to the deep plane entry point, we want to be subcutaneous. Superficial, hydrodissecting the skin. Posteriorly, we want to be hydrodissecting the skin off of the dense fibrous fascia over the sternocleidomastoid muscle and over the platysma. More medially, we want to be deep because we want to be on the surface of the zygomatic musculature, so these injections will be deeper, and it's good to supplement some of the injections along the deep plane entry point because we want to thicken that layer, because that's where we're going to be entering, and we want to create a little bit more thickness or distance away from the facial nerves which are underneath. So next, we want to mark where the tragus meets the root of the helix. I mark that with a 15 blade, and we make a curvilinear excision of the skin following the the root of the helix. Similarly, we want to mark, we look under the flap, and I'm looking for the area of that step, geometric step off of the intertracheal incisor. We mark that, and in this one, we're going to be making a more of a geometric rectangular cut in that spot, so it fits right over where that geometric closure, that geometric break was. And when that break is going to allow there to be a hollow right before the tragus, a pretragal hollow. And we want this tragal flap to be redundant. So that there's no tension, so we don't get any pulling on the tragus. Again, 1.5. The skin just lies down because there's no tension required on the skin because of the deep plane release of the face. When I used to do smash facelifts, I used to tug on the margin of the skin because I was worried about the facial tissues loosening, because it was often for me to need to do tuck-ups on my patients who I was doing smash work on. Now, I just let the skin lie there, and I don't need to do that cut. So I transitioned to deep plane surgery when I was in practice, at about 6 or 7 years in, I think. So I'm going to trim the skin around the earlobe, and you have to be conservative here. When you do these limited incision procedures, you should put a suspensory suture for the skin for this flap. So taking a bite of the deep fascia and one tacking suture of the skin to make sure that its position is stable and there's no distortion or pulling on the earlobe once we close it. So see how that tacks the skin down. Scissor to me. And I'll probably put one more right here because the skin here is scissor. Okay, very cool. Seems a little bit loose. It needs some support. You can see how that flattens out, that little bit of a bulge. You have to play with the skin a little bit. Use some deep suturing and make sure that it's as smooth as you can make it. 5/0 nylon. So you see there's no tension on the lobe whatsoever. There's no risk of this patient getting a pixie ear. The lift is really predicated on the deep tissues, and there's no tension on the skin. So you can see post-auricularly a little bit of ridging from abbreviating that incision. That'll flatten out. All it's left to do is the closure of the tragus. I usually use a plain gut suture because it's very painful for patients to get those suture removed from the retrotracheal incision on the inside. There's lots of nerve endings there, so I use a dissolvable suture there. Cut. Okay, can I get another longer 5/0? Okay, the plane. cut. Okay, great. So we're all finished. This side, marking pen. Okay, template. So we're going to start again. Lobular facial sulcus, geometric back cut at the intertracheal incisure, staying along the root of the helix, transitioning just behind the tragus. We don't want to dive deep in. That causes distortion. And then we're going to limit the incision a little bit here. Probably going to take it up a little bit further, knowing how much redundancy we had on the other side. And then staying on the back of the ear, just about 1 millimeter or 2 above the next skin sulcus, and leaving a little bit of skin past the crease, about 1 or 2 millimeters around. Starting again with the subcutaneous elevation. And then we're going to be transitioning again to using a backlighted flap technique. With the bear claw. So we're going to be elevating the skin again to the deep plane entry point. Again, transilluminating the skin flap, looking for a nice yellow color, not white, that would be too bright, not darker, that would be too thick, the flap. We want to make sure the flap is elevated up high enough into the temporal region so that we don't have any problems with redraping the flap as it comes up vertically. Starting the skin flap from below again, same way, double prong. Elevating it, top of the fascia, over the sternocleidomastoid muscle, just to get a ledge. And then we'll transition again to a backlighted flap technique. As the skin flap begins past the SCM, we're using blunt spreading to elevate the skin over the platysma. A lot of this dissection was completed earlier from the midline approach. So this flap was already elevated from the midline from before. So it was easy for us just to pop through that. There was less dissection that was required. So I'm engaging the deep plane flap, lifting up. We're pulling up with our hand, and then we're scoring the deep plane until we see the fascial layer. And we see that popping up right there. It's that white fascial layer. Coming up again, following it up to the lateral canthus, scoring the tissues and separating by pulling, and then up at the top, we're looking for fibers of the orbicularis right there. See those little red fibers, bipolar. And then we're going to start elevating the flap. A little bleeding there. So inferiorly, we get under the lip of the edge with this lip retractor, and then we spread over the masseter. See, this is a very easy plane to dissect. These are the masseterocutaneous ligaments that we're releasing because the masseter is down. That's going to allow us to redrape the jowl better. We didn't talk about that so much on the other side. We were focusing more on the mandibulocutaneous ligaments and the zygomaticutaneous ligaments. But as we elevate the SMAS off of the masseter, this is the masseter muscle, and here's the anterior edge of the masseter muscle. It's all the way to here. So you really need to release all of the fascia over the masseter if you're going to release the masseteric cutaneous ligaments. That's what limits the redraping of the jowl area. So we go back under here, we see we have that flap elevated. We start to go inferiorly. So we're under the platysma again here, and we want to follow it all the way down 5 centimeters below the gonial angle and back to the SEM. But again, if we look at where we are, we're all the way under the jowl. The tendency is to want to continue the dissection from inferior to superior because it's an easier plane of dissection, but you'll get under the zygomaticus muscle and starts to affect and put at risk the buccal branches and the zygomatic branches of the nerve. The proper way is to go from top down, because once we define the plane on top of the mimetic musculature, we can't hurt anything because all the facial nerves come from the deep surface of that. You can see here the avicularis fibers. So now I'm above them, and I want to see fat up in the flap. So you see the yellow fat that's up here. So we want muscle down and fat up. I'm going to take that dissection all the way medially. Again, all the way to the nose and under the eye. So once we look in here again, now we have a superior pocket that's on top of the mimetic musculature. We have the subsmass pocket. Here's the ligament. Give me a blade. And this is what fixes, if we look overhead again, this is what fixes the midface. You can't move it if you don't release this ligament. It's not possible. Suture suspension techniques cannot get through this. This is a very dense fibrous ligament. And important point is that, again, it's much more inferiorly placed. It's along the inferior border of the zygoma, where it articulates with the zygomatic arch. So it's not up high, it's actually quite low. So now we can see, here's that ligament. We're going to release it. Stay on top of the zygomaticus musculature. And we see these are muscle fibers here. And once we start to get through the beginning of the ligament, usually we can just bluntly spread and follow the zygomaticus musculature down on top of the zygomaticus musculature, and we're following it all the way anteriorly. And again, if we're on top of this muscle, the zygomaticus muscles, then we can't hurt anything. The nerves come from the parotidal-masseteric fascia here, and they come under the zygomaticus muscle. So if we stay on top of this with this dissection, then we're safe. So our dissection is under all of this tissue. So now when we redrape it, we will have no transitions through the face. And now when I lift that, you can see how the mouth posture looks the same as the other side. It's not downturned. It's going to be elevated like the other side is. So as we get older, the lateral oral commissure starts to descend, and it makes us look sad. And putting filler under the oral commissure doesn't make it look more useful. So lifting it is really the answer. Marking pen is now placed along the border of the SCM and the platysma, and then I score that, and then I take a long forceps blade, great. There's the cut. I lift up on the edge, and then I lift up and spread. And I'm just going to make sure that my dissection is complete over the area where the mandibulocutaneous ligament is. And it is. So we're rolling above the jawline. So we know we have the ligaments released. Irrigation. So that's the deep plane flap dissection is complete. More bipolar. And this is an antibacterial solution. Bacitracin and gentamicin, light away. So if we look in here again, we'll see the zygomaticus musculature, the parotidal mesenteric fascia. This is the deep cervical fascia down. This white stuff here is the cervical retaining ligament tissue that's right over the SEM that we're going to grab on for that platysmal flap. First suture goes in the most inferior part of the flap. Nice part about the deep plane approach is that this patient has very thin tissues. So if you raise a long subcutaneous flap in her, you would have a much higher likelihood of seeing irregularities and problems post-op. Leaving that thick blanket of SMAS and fat in the midfacial portion of the flap doesn't allow that to happen. It's a more robust flap, so it'll also have better blood supply. She does have a very thin face, not a lot of subcutaneous fat. So we work it again from inferior to superior, taking bites into the dense fascia and the preauricular region. Here she has a little gap again like we saw because of that area where she has a concavity in the face and less soft tissue. So we'll bypass that. We don't want to put a suture into that subcutaneous tissue because it's too thin. It'll wind up looking like a little depression that'll last for months. Working our way up. The more superior sutures, and you can see this if you look over top, this more superior suspension sutures are what elevate the midface. So we're going to start by suturing okay, hold this. The most inferior portion of the flap first. Scissor. Working our way up. Hold this here. Again, there's not a lot of tension on these sutures because they're just holding the flap that's been released in the position I want it. We don't need to tug against the ligaments that haven't been released. They've all been released. Scissor, please. Let go. Great. Long forcep. Okay. And here's that. Platysmal flap. Scissor, please. So I'm just putting in a second suture into that platysmal flap. And then lastly, placing a suture into the inferior SMAS and rotating it over the gonial angle. Scissor, please. Great. So now that flap's been repositioned, we're going to inspect the submental area. Long forcep. Okay, long forcep. And she does have a bit of a submental pouch of some fat. So I'm going to remove that fat in the suprahyoid region. There's not much of it, she's a thin lady. But that's going to give me access to the medial platysmal edges. Suction cautery. So I like using a suction cautery to remove a little bit of extra fat instead of using liposuction. This will suck away and cauterize some of that extra tissue. Right. And if we look at her pictures preoperatively, again, I'm just sculpting away. Some of the extra fat in the midline, and then you can see right away how much better contour that already is. You can see that she has some medial platismal redundancy, and I don't. It is laxity when I'm expecting that area. So what I'm going to do is I'm just going to plicate the medial edges together. I've removed the fat in between them. That was excessive. This is the medial platismal edge on this side, and I've released it underneath the platismal edge, and I'm going to do the same thing on the opposite side. I've released the medial platismal edge on this side. I make a little back cut at the level of the hyoid to interrupt that platismal band, and I'm going to do the same thing on the opposite side. I've made, at the level of the hyoid, I've made 2 horizontal cuts in the platisma. So that's going to allow the verticality to be released, and then I'm going to rotate this 2 platismal edges forward and plicate them in the midline, which is going to create more definition. And the cervicogmental angle. So, vicral, taking a bite of one side of the flap. I suture the edges together. Another bite of the medial platismal edge on the right side. I'll take a bite of the intermediary fascia, the deeper fascia, and then a bite of the other side. Suction cautery is next. And as I do that, I'm contouring. So these are all being placed between the 2 medial platismal edges above the hyoid. I'll probably place 4 or 5 in her scissor. So now if we look at her profile view, we can see how this is nicely recessed into the cervicogmental angle with those back cuts and with the platismal flaps and the central interplatismal flap being removed and brought in. But if we look at her over here, we can see the lack of definition in the suprahyoid submental region. Place the drain again. And then cut again here. We'll trim the skin. So we're 4 hours and 30 minutes in. Mark for a lateral temporal lift, fat graft, lip lift, pinched lower left, cantoplasty, deep plane facelift, and a small suprahyoid platismoplasty. Blade. Four nylon. Marking pen. I got a blade. Micro. Okay, bike roll. 5-0. Let's get it. Cut. Cut, please. Double prong. Round. Blade. 4 out. Blade. Cut. Blade. Bike roll. Four nylon. Cut. 4 bike roll. Cut. 4 nylon back. Blade. Mark. Okay, blade. Marking pen. Sorry. Sorry. Fresh blade. Scissor. Need the stores in a minute. Vicryls next. So again, that's a suspensory suture for the flap. Holds it fixed in place and it prevents displacement of the earlobe. Okay, 5-0. But you see there's no tension on the incisions, there's no tension on the skin, there's no tension on the earlobe. All the tension of the repair is on the D-plane entry point. Okay. In cases where the neck is more problematic, it's not uncommon for me to, treat the full length of the platysma. She really only had a super high platysmal problem. I'll often reduce digastric muscles, which she didn't require. And occasionally I'll remove the submandibular gland. Not remove it, I reduce the size of it, debulk it. So you can see a very defined cervical middle angle. The suprahiaplatism has been treated. We have a nice flat plane. The lateral platysmal flaps have given a lot of contour, and between this and both platysmal flaps, with back cuts to here, pulling on the medial platysma, we get a very sharp contour to the submentum and the cervical middle angle. If you look straight on, the midface is up. You can see the corners of the mouth are elevated. The cheeks are high. The lower third of the face is tapered. All this volume has been repurposed and positioned up higher. And with the lateral canthal tilt and a lateral temporal lift, her whole face looks more heart-shaped. She'll get a lot of volume correction along the gonial angles from that SMAS flap. And I think that she's going to have a great result.